health in India. I welcome today's guest speaker, Dr. Aparna Hegde, Madam. Madam has done her MS from Stanford University and fellowship in urogynecology from Cleveland Clinic. She is Associate Professor of Urogynecology and Head of the Department of the same at the Kama Hospital, Grand Medical College, Mumbai. She is founder of NGO Arman, which creates scalable programs using technology innovationally to impact maternal and child health. Arman works in 20 states in India and has 5 programs, reach more than 32 million women and their children, trained over 260,000 health workers. She is a member of the editorial board of International Urogynecology Journal and the 7th International Consultation on Continence and International Urogynecology Committee on Products. She is the chair of FIUGA, the Foundation for International Urogynecological Assistance, and of the Ayuga Publication Committee. She is an NIH grantee for her research in dysfunctional wedding. Dr. Hegde Madam was listed by Fortune magazine as one of the world's 50 greatest leaders 2021 and also has been awarded the Women Transforming India Award by NITI Aayog in 2022, MIT Levitt Award in 2021, the Ashoka Senior Fellowship in 2021, the Trade Fellowship and the Skoll Award for Social Entrepreneurship in 2020. Dr. Hegde and alumni of MUHS, and now she will deliver a lecture on technology innovations for maternal and child health in India. Please welcome Dr. Hegde Madam.
Give this presentation in your presence. I've been looking forward to meeting you and the role model that you are for everybody in medicine in the country. And the pro-VC man, sir, I've known him for 3 years, and so it's great to meet him again. And wonderful dignitaries here and members of MUHS. After coming here, after meeting Mr. Mathur in the digital health meeting, I realized how proactive and helpful everybody is in MUHS, and it really gladdens my heart because I'm a product of MUHS, and I came back to India with this whole dream. My work and what I've done comes from what I saw in MUHS, in Sion Hospital. And so I really, it's close to my heart, the work that I do, and everything has roots in the training I had in Sion Hospital, and henceforth. So to come here is an absolute honor, one of my milestones in my life, So thank you so much for this. So I'm going to talk about Arman and a little bit of Kama Hospital, what I'm doing in urogynecology, right? And so I know I'm talking in front of a medical community, but I'm going to recount what led to Arman, and the kind of stories that led to Arman. Right? Arman right now is in 20 states. We are going to go through the country in the next 3 years, all the states of India. We've having massive reach, but all started from what I saw in Sion Hospital. And I think any of us who've done the gynec residency would know the kind of patients we see and the kind of high-risk factors we see. I did, residency in Sion Hospital. There were 70% of women who came from the depths of Maharashtra, and high risk. They were the first hospital on the highway. And it really boggled my mind that absolutely preventable reasons led to loss of lives in very horrific situations. Things that should never happen. We were doing heroics in Sion Hospital, but we shouldn't be doing those heroics. It's not right because what the women and children were going through was unacceptable. And I'm going to recount one story. I'm sure you've seen these stories and it just, kindled those memories back. But this story is very close to my heart because that really led to a transformation in how I viewed medicine and what I was doing with the training I had. So this is a patient, Anita, of course, name changed. She, in the 3rd month of pregnancy, went to Thane Civil Hospital for regular antenatal care. Right? And we all tell patients this, right? Come to the hospital. That's what government says. Come to the hospitals. Deliver in hospitals. She went. But of course, Thane Civil Hospital, very good hospital, but 200 patients waiting outside, extremely overcrowded clinic. The nurse there had absolutely no time to even look at the woman's face, leave alone counsel her. And anybody who's had a child knows that things change from week to week, right? And so you need to know what to do in that particular week. But 5 hours of waiting, hot, humid climate, heard her around. She never went back. Didn't realize why she needed antenatal care. And 5th month developed gestational diabetes. That's diabetes in pregnancy. Now when you have diabetes in pregnancy, often the baby dies in the womb, but no baby survives. Unaware, she goes into labor 9th month and goes into labor Friday evening. Worst time to go into labor in Mumbai city. Everybody wants to transfer to government hospitals, Friday evening patients. So she goes to Thane Civil and look at the chain of events. The nurse there, not trained in that peripheral hospital, the nurses are there, right? So, not trained in multiple years after the first training, didn't realize there's a problem. And started delivering the baby. And the baby obviously was exposed to so much sugar in the body, so the baby's body was huge and the head remained small. And so the head delivered and the body remained stuck inside. Shoulder dystocia, you know that, right? So the baby died immediately. Now it's a question of saving the mother's life. And this is my first 3 months of residency, so the nurse there called the doctor down. He was doing, private practice somewhere. It took half an hour for him to come down. It took half an hour to get an ambulance because we don't have a 911. Now things are changing, but those days there was not. Why did I have to get an ambulance? Because there's an operation theatre upstairs, but no anesthetist on the work hours, so they have to transfer. So 1.5 hours after she comes, the baby's head pops out, she's transferred. And it takes 1.5 hours more to the horrible Mumbai traffic to come to Sion Hospital. And I was the first poster, it was our emergency date. I was in the receiving room and I've recounted this story countless times and I get goosebumps when I remember the mother. We opened a petticoat. There was this black bonny baby head sticking out of the vulva. Beautiful, baby is a bonny baby. And then she was sinking. Her lower part was gangrenous, literally, congested. And this is just when the mobile phone was coming to India. We were working with, without it. And I ran to the hospital, got all my seniors. They all came down. We tried to take the baby out from below. It was not possible, all jammed. So we took her for cesarean section. My seniors scrubbed up. I was unscrubbed, only junior making things ready. They operated, but they couldn't take the baby out from above. It was jammed. So the deal fell on me. I had to behead the baby on table. Take a knife and behead the baby on table. And because you cannot give a beheaded baby to relatives, I had to get needle and twine and stitch the baby's head of the body. In the first 3 months of my residency in Sion Hospital. And then she died 3 days later. And this stuck with me over and over. I kept seeing these cases over and over again. I've seen patients where patient coming eclamptic, convulsing in hypertension, and I opened her papers. 3rd month I had seen her in the OPD. And I was racked with guilt. Had I not told her the danger signs, complications, why she needed to come for care, because it's so overcrowded. So and this is a state in India, right? If you look at India's numbers, if you look at urban numbers or rural numbers, India counts 9% of maternal global mortality. In the next 1 hour, 3 women will die in childbirth somewhere in India, even now, right? 2 children under age 5 die every minute in the country. If you look at Mumbai, 45%, 70% of women are anemic, literally. Like if you consider moderate anemia, it's 70%. 45% of children are malnourished, and I saw the gender divide. Like the proportion of girl children who are malnourished is so huge. There are more 22,000 deaths of girls as compared to boys under 5 because of the breastfeeding gap. And recently I read some statistic that really boggled my mind because we really go in gender transformative approaches. And what really bothered me was that if you do not have enough nutrition as an under 5 child, then for girl children especially, there is 72% reduction in cognitive ability as an adult. So what kind of, background or, support are we giving child when born? And I kept seeing the cycle of malnutrition, right? Adolescent girls becoming pregnant, giving birth to adolescent, underweight children who then grow up to, become adolescent girls, So, and then what really bothered, the 2 things I realized. If I really want to impact lives, I have to go into the community. But work on systemic problems. I cannot do one-off things. I have to work at a systemic level to bring about systemic change. And I have to work at scale. Because India's magnitude is so huge that if you want to really impact lives, you have to create solutions at scale. So for that, I have designed for scale from day one. And the 2 problems I realized is that one is you have to get care from the delivery point, pre-delivery, or after child is born. So pick up risk factors in time and treat them in time before it's too late. For that, I would do 2 things. One was, women need to be informed. And not just once, weekly, when they need that information, directly in their homes. Right? Like handhold them through pregnancy and infancy, so that they will demand care, access care. And on the other hand, I would train health workers at every level of the cadre, ASHAs, auxiliary midwives, medical officer specialists, to be able to give that kind of care at the appropriate time, so that risk factors are picked up early enough. And then because magnitude is so huge, suddenly that time mobile phone spread to the country. And in 2008 is when I founded Arman BV, and this idea has been bubbling in my head from a long time. In fact, if you know Sneha organization, Sneha, Armita Fernandez Madams, that organization first program I had written, the City Initiative for Newborn Health. I had written a plan to overhaul Mumbai's public health structure as a lecturer. After doing MD Gynec, went back to science as a lecturer, and I had written the plan to overhaul Mumbai's public health structure for that, Sneha. At that point, I was visiting all the hospitals, a lot of these ideas came in. And then I realized I have to create cost-effective solutions, scalable solutions. And then I got to Stanford and I went there and iPhone had come there. 2008 is when iPhone first came. I had a feature phone. My friend from Sion Hospital doing hematology there had iPhone. She bought the first iPhone. And I realized no time, a smartphone will be in the hands of almost everybody in India. And this is happening now. If you look at India, Mumbai, 80% of women have access to smartphone. If you look at rural India also, there's a 40% literally have a smartphone per household. So what struck me was that if I have to design for scale from day one, I have to use technology, but I have to use technology that is easily upgradable by the women themselves. Those days, when you talk about technology solutions, people will create a new device. Oh, I'll create a new device which does e-pathogram, or I'll create a new phone that will photograph and tell you. But I cannot build a new device which will go through the country, in a country where BP machines don't exist in so many primary health centers. Creating a new device doesn't work. What I have to use is what is easily available with the women. Sorry, I'll just put it on. Yeah. And what they will upgrade themselves, and I can upgrade then the solutions to keeping pace with the technology upgradation that they are going through. I'll just put it on. Yeah. So, this is when the whole idea of using technology came in, and mHealth, mobile health. And I'm very happy to say we were the first one in the world to use mobile health. To use, for the first time, on the one hand, inform women about the care to be taken during pregnancy and infancy, so that they demand care, access care, know the risk factors, go to the hospitals. And on the other hand, train the health workers at every level of the cadre to be able to give the kind of care early enough. And our goal, 2030 vision is that the number of women who end up with high-risk children is more than 50%. I mean, if I incorporate moderate anemia, it will go 60-70%. We want to get down 25%. This is our goal. Delayed referrals and complicated referrals should come down. High-risk factors will happen, but they should get picked up in time, treated properly, and that is our goal. And the way we do it is this, right? We have 4 pillars, and I'm very happy to say those pillars are written down from the day one, and they've stuck. So thing is this, we use technology, but we don't use only technology. We call it tech plus touch. What does it mean? You can't just take somebody's number, send call. I just can't send information to the Asha on the phone. You have to have touch points. For feedback, for enrollment, for two-way communication. But because I'm using technology to do the heavy work of going weekly, I can keep the touch points required to the bare minimum. So it becomes cost effective. So we call it tech plus touch. All our programs follow tech plus touch. Second thing is that we do not develop our own parallel infrastructure. A lot of times those days, NGOs would be like, oh, I have my own network of health workers on the ground. But that is parallel to the government. I realized early on that it will not scale up. Secondly, you have to strengthen government systems. Government has a really good network through the country. Help that develop. Leverage that to create scale. And that's why we leverage existing health infrastructure of the Government of India and partner NGOs to scale up. Third is we are very evidence-based. I'm a researcher. Everything you see now, because of lack of time I can't go through every research study, but is evidence-based. Every nuance is evidence-based. Proved, tested, then scaled up. Lastly, now we are going on to equity-based approaches. I'm going to talk about that because even in the underprivileged, there's a last mile of the last mile. Look at migrant mothers. When you look at young adolescent mothers, if you look at SC/ST, their needs are different. So I have to create nuanced programming. Earlier we were equality-based lens, one program, all underprivileged, but it doesn't work. So it's equity-based lens and gender transformative approaches. Gender plays such a big role. Earlier you would think I'm an NGO, woman-led in your organization, serving women, so it's gender sensitive. It's not like that. You really have to build solutions that are transformative, that help the woman rise up and demand her rights, and the husband realize that it's their child and they have to work together. So we use gender transformative approaches. Everything in our programming, content, the way we deliver the content is gender transformative. So we're doing a lot of research in it also. Yeah. So, as I said, theory of change is this. One hand inform women, the other hand train health workers. I'm going to go through one of the program. Yeah, our journey. I just want to tell this because there are students here. You will have ideas, you will have dreams. Persevere. Stick to it. It took me 5 years to get the first penny into Arman. It was a very difficult journey. 2006, 6 is when I thought, oh, I have to build my own organization. I had a lot of these ideas, but I realized I have to build my own organization, can't depend on other people to do it. But then thinking and building is a very different thing. 2008 I founded it. It took me first 5 years of knocking on all doors, running everywhere, because what happened in those days, scaled solutions were created by multilateral agencies. WHO, UNICEF, John Hopkins, not by Indian, like NGOs. And you tend to be community partners. There's great NGOs, Indian NGOs, right? And they're at scale. But in health, it tended to be like your community, you're the partners, on the ground. Secondly, technology-enabled solutions were not there. So when I was at Stanford and knocking doors there, money was there. In India, by then CSR with 2% thing had not really developed. So I didn't know where to go, whom to approach. Medicine doesn't train you in all of those things. So I'm trying to convince all the international multilateral agencies that okay, homegrown, a fellow-led organization will develop technology-enabled solutions where the MD doctor heading it does not even, he had never worked in technology. It was a very, very, very difficult task. So 5 years was like, every penny, of mine went into developing, prototyping, proving, but finally it paid off. In 2011, there was Saving Lives a Birth event at, at Washington DC, where all the, by WHO, Gates, the World Bank, the government of Norway and Canada had all come together, and they had this competition called Saving Lives a Birth event. Sorry, Revolution was not involved, the other entities were involved, and we won the People's Choice Award there. And that's where people started noticing us. And there was, it was like, I remember ABC News mentioned a tiny NGO called Arman from India, 3 people, and we were, so it was a big world stage, and the audience were the who's who of the public health world. And then there's something called as Mobile Alliance for Maternal Action. It is a consortium of USAID, J&J Global Contributions, Baby Center, and UN Foundation. Health Alliance, international. They had come together. They were South Africa. They came to Bangladesh, and when they came to India, they had heard me. They funded us to scale up our program. And that's why. So 5 years, but once we took off, we really took off. So that's what. Now there's one take-home message. If you have an idea, just stick to it. Keep at it. Things will work. Something will not work. So many failures along the way. I've had so many doors slammed on my face, but those doors have now opened. We were collaborating with them. All the people I'm knocking my doors on now are our collaborators. So it works. No ideas, if they have merit, fail, and if you, persevere. So what did we do, right? I'm going to give you briefly ideas about what programs are, right? So the first program was something called as M-Mitra, Mobile Mitra. Mobile Mitra is mobile friend. And again, every nuance of this program is evidence-based. So I said the one program we worked on was on lack of access to preventive care information. So we want to handhold women through pregnancy and infancy weekly on what is going to happen in that particular week. Reinforce important information from the past. For example, anemia, you keep on telling them, right? Handholding them on what can happen, when, what to take, what can the complications, how to take care of the complications, constipation, etc. Like you will keep on supporting them, and then introducing important concepts for the future. Like if I were to do sonography in the 20th week on congenital anomalies, 16th week onwards, you start introducing the idea to the woman that you have to go and get it done. So every weekly message had that kind of those 3 components. So M-Mitra was a free voice call service. Why? Because we had done a study in Dharavi which showed that SMS does not work. Even in Dharavi, 70% of women could not open an SMS, read an SMS, send an SMS. A free voice call in an elder sister voice. Because we wanted them to think that people cared. Like a voice coming to you weekly in your ear. And these are women, I'm telling you, pockets of rural poor. UP, Bihar, they come to Mumbai, they're separated from their community, they're married off to somebody they don't know, living in Mumbai, illegal settlements, no healthcare access because it's illegal, language they don't understand, very alone. And then they have an elder sister coming to you weekly. They did not even realize it's an automated voice call. They would think that actually Didi is talking to them. We would get calls saying that Didi ko takleef hota hoga, bar bolne ka, like they literally felt somebody cared for them. So twice a week in pregnancy and literally twice a week in infancy, with 142 messages, till the child is 1 year of age, we would send automated voice calls in their chosen time slot. Because if their husband has a phone, then they can keep the phone with them at that particular time. And language preference. Went to 6 languages, and we would enroll women wherever we could get them. So women were in hospitals, right? They come to antenatal clinics. So we had a health worker stationed in government. Oh, I'm so sorry. 1 second. I'll just put it off. Yeah. So we had women stationed in government hospitals but we didn't tell them it's an NGO doing it. We told them it's a hospital doing it. So they would feel that the hospital cares for them and they'd come back for care. It became a part of the regular care. They would come, give the blood pressure, do the pressure, and then come and get enrolled into MITRA. At the time of enrollment, a health worker would take their phone number, gestational age or age of the child, because the information is timed and specific to the age of pregnancy, age of the child, language preference, and time slot choice. But women come to the hospitals too late. So we also formed partnership NGOs on the ground. What we did was we incentivized the health workers of existing NGOs. They were anyway going in that area, you would more likely to know who is pregnant in that area. So we incentivized them financially to be able to enroll women as early as possible in pregnancies. They get information for longer time. Over time, we partnered with 100 hospitals and 40 NGOs on the ground. And we had 8,000 health workers incentivized. And we went to 9 states in 3 years. It spread like wildfire, 2.9 million women. And I'm very happy to say it started off with an RCT. And this is MUHS, someone say that everything started off as, studies which proved, and it's a DFID funded RCT, DFID UK, first study that. So it's a 3-arm RCT we did. Group A was control group 84 villages, Group B was MMITRA, Group C was MMITRA plus home-based care. So that higher bound can be compared to the control and control the higher bound, right? So when we did that, we had, and it is Osmanabad, Solapur, Washington, 50 villages we did. And I'm telling you, look at the, we had midline study, end-line study, and the end of pregnancy and infancy to show impact. I just want to show you a couple of things. If you look at proportion of, look at the lower one, right? Proportion of women who took IFA tablets for 90 or more days, because those days 90, then it became 100. Look at the middle group, 70% as compared to control of 45%, Control to 45% and MMITRA group 70% improvement. I mean 70% of women actually took IFA tablets. And if you look at the third, highest bound, 83%. Right? So it is comparatively, p-value, those are p-values. A p-value, of course, of the highest bound is more, but it is comparable, right? 73%, 70% is good for a voice call service. And if you look at breastfeeding indicators, we don't have time, but all the breastfeeding indicators, look at this. And if you look at the p-values on the right, they were comparable to the highest bound, the improvement in the MMITRA group. And I want you to, look, there's one, sorry. And it's going back. Yeah, there's one indicator I want to talk about is, it's not there in this slide, proportion infants who tripled their birth rate at the end of 1 year. We found almost 20% improvement in that, just from MMITRA. And we also did a pre-post intervention study in Sion Hospital, where it all took off. And we showed that when you send MMITRA, more women access care during complications and less number of women end up in a delayed state. And when we did this, Government of India came to us and said, why don't we take over their Kilkari program? Just a little after we started MMITRA, with Gates and BBC Media Action, around the same time actually. The Government of India had taken it over, and in 2018, government asked us to take over Kilkari program from Gates and BBC Media Action. The term had ended, and we took it over with the caveat that we would augment the programs. Now, Kilkari is a similar program to MMITRA. Kilkari has now reached 30 million women in 19 states of India, 5 languages. It's 1 message a week, voice call. But we are doing augmentation of it. I'll tell you what augmentation we're doing. And just briefly, this is a study on Kilkari. Sorry, why is it going? Yeah. Again, Kilkari has been supported by an RCT done by Johns Hopkins. And I will not go through all the indicators. But this is a cross-sectional study of 4,000 women and their spouses, which showed that when you have exposure to Kilkari on immunization, it increased knowledge of the husband's knowledge on immunization, led to increase in timeliness of child receiving vaccination at birth, increased the number of women who knew the child should receive the first vaccination at birth. A lot of indicators showed that Kilkari improved, child health indicators. There are multiple other indicators that we studied. Yeah. So I'll come to augmentation later on. I'm going to go on to the health worker side. So now I train women, inform women. through pregnancy and infancy, handhold them, they're going to access care. On the other hand, you have trained health workers. You have 3 levels, right? The ASHA, A&M, medical officer, and then the specialist comes in. So the ASHA training program, also we run for the Government of India. It's called Mobile Academy. So when the ASHA, there's an ASHA in every village. But they get a 20-day training program, but the refresher training program is mHealth based, and that is run by us. It's called Mobile Academy. And we have trained 266,000 health ASHAs now in 18 states of the country. Both Kilkari and Mobile Academy go through the country now in the next 3 years. Mobile Academy initially again was voice based, 4 hours of content. ASHAs could log in and log off whenever they want to. There's a bookmarking system, so they log back in where they left off. 11 sections, 4 chapters within each section, a quiz at the end of each section. And again, we've done evaluation studies on this, and I just want to show you a CACI survey which showed that, you know, it is done in Jharkhand, Madhya Pradesh, Rajasthan, Uttarakhand, and they showed that, I mean, 99% found that the knowledge really gained, you know, they had knowledge gain, and they 99% used the knowledge, you know, when implementing their services. Yeah. Now, what I'm very interested in talking about is the version 2. And that is where Arman has really worked hard to develop nuanced programming, fit for purpose approach. I told you that we had an equality-based lens. I have a program, I send it to everybody. But now, it's going to be based on technology access, based upon degree of inequity and based on degree of high risk factor. We are going to have different programming, nuanced programming. We'll have multimedia, more two-way communication, more hand-holding based upon need. There will be targeted messaging, in fact targeted to an extent where, you know, for each equity, issue like migrant mothers or Muslim women, adolescent girls, we will have targeted content for them which speaks to them directly. You know, we'll also go through self-help groups if required. So we're testing all of these different parameters. So I'll just go through them. Right? Before that, I talk about how we also work with the government through systems training. So when I talk about version 2 of Kilkari and Mobile Academy, it has got 2 components. One is the programmatic component, which is like technology and content, and that is version 2B. But 2A is a lot of systems training. And what do I mean by systems training? Kilkari and Mobile Academy are Government of India programs, but there needs to be more integration within the states. There needs to be data-driven approaches. There should be review of the program at every level of the cadre. And there should be improvement in RCS database. Kilkari and Mobile Academy take data from the existing live database of mothers and children of every state of the country. Each state has a live database of mothers and children, but the data quality is very, 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 very poor. Why? Because the health workers on the ground have no understanding of why the data is important. Why do I have to import right data? The phone number or any other, you know, antenatal care data. So when will they start doing the right inputting when we train them, handhold them, also send data back to them analyzed so that they can have data-driven action. So we're going to do a lot of efforts in data training. We're going to send analyzed data back to every level of the health cadre. We are going to be ensuring that the data gets reviewed at every level of state system so that data quality improves, programmatic improvement happens, and that will lead to improvement overall in Kilkari and Mobile Academy's reach. And we are building state teams all over the country that will work with the district level people to ensure this happens. And when I look at Kilkari version 2, and this is a busy slide, I'll just tell you what this means. This is nuanced programming. On the x-axis, your risk factor. For me, equity also risk factor. Right? So low risk women, high risk women, equity encumbered women is the x-axis. The y-axis is technology axis. If I have feature phone, I'll send you voice call content. If you have WhatsApp, I'll send you WhatsApp-based multimedia content, but nuanced programming. So everybody, it's a pyramidal structure. Every child and mother is low risk, LOW, low risk. There's no risk. So low risk women and children will have a baseline program. That baseline program can be IVR or WhatsApp-based multimedia based upon what technology you have. But if I have high risk or if I am equity encumbered, like pyramid, it's like a pyramid. I'll have more and more content, targeted content, more multimedia content specific for the high risk factor or inequity. I will have more hand holding. They can ask me questions on the call center or WhatsApp help desk. And we are developing channels. I tell you the problems we are facing, right? Like if you look at equity, you have migrant corridors. right? You have UP, Bihar corridor going to Mumbai, right? One corridor going to Andhra. So we are actually working with migrant organizations where they are tracking the women and children, and we will do the servicing. So nuanced programming like that. When I'm working in a tribal area, we're going to work through self-help women's groups. Because there are parts of the country where the language they speak, no one else speaks. Even the Asha doesn't speak. And there's so much distrust in the health system. So there, why can't we, there is self-help women's groups, because the women are drawn from the village to go to the women, So we, similarly, if I'm looking at Muslim women, they also underprivileged. So content should have their language a little bit, right? I mean, that makes them feel at home. There will be more support from people who understand their issues. So for every, equity issue, we have nuanced programming being developed as I speak, which will become part of national program. Same thing with Mobile Academy. In Mobile Academy version 2, what we're doing, now the good thing is every Asha has a smartphone. So what we're doing is every piece of content we're going to teach is becoming multimedia. Live action videos, simulations, interactive quizzes, and we want to do hand-holding. See, teachers here, one cannot teach people only once. You have to teach, then reinforce, and then hand-hold. So teach face-to-face, but then after that, because they have a tablet or a phone, through multimedia sources or app development, app may not work, they have WhatsApp. So through WhatsApp, we can send content and keep on reinforcing. And then when they go into the field, they have any queries, they can ask us on WhatsApp help desk or call center. The whole thing is this, right? Like tomorrow if there's a new pandemic or new vaccine, if you have this whole cadre of Ashas who are in constant touch with us, they don't think it's Arman, they think it's government. We're doing it for the government of India. And then they trust that source of training. So the next pandemic, we can send information directly, easily, and handhold them, right? New vaccine comes in, the training can go fast, right? Through Mobile Academy. That's where Mobile Academy is going now. And this is like the grid. Right? So we have x-axis you see skilling and capacity building and long-term handholding, and y-axis is your access technology. If I have feature phone, then IVRS content. If I have WhatsApp, and if your database, phone data allows it, then it's thin app. App is not the solution for everything. You have to create targeted solutions. Yeah. So where are we? MMitra and Kilkari convergence, right? The way we are working is, now MMitra was a base program. Now MMitra has become a sandbox. MMitra has a rural sandbox and an urban sandbox. We test everything in MMitra, scale up through Kilkari. Everything I'm talking about, WhatsApp, high-risk factor, equity is getting tested, and then scale up through the country. As I speak, we have 10 pilots going on. We have a research team of 3 directors and a big research team. It's like a department of research in Arman, literally. One thing I'm really excited about is the use of AI. So Arman is a collaboration with Harvard and Google. And what we've done is, because we deal with big data, 32 million women and their children, and so many health workers. So we are one big example of a model of AI being actually used in public health. AI has been spoken about a lot, but actual implementation large scale is Arman's with Harvard and Google. We've actually developed a model to data crunching over the years, where we can now predict the time of enrollment itself who's likely to drop out. See, when we proved that if you listen to the voice calls, if you listen to the content, it's going to improve your health outcomes. But they may drop out for various reasons. If I can predict who's likely to drop out, then in a decentralized manner, I can get the Asha to visit her. I can get the health workers on the ground to ensure that the woman comes back to the system. So we are now able to do that. In time of enrollment, because of data crunching, we are able to do that. And it's been published over and over again, lots of publications on it, and now AI is going to get used in our programming at every level. We are hoping, because we work with high-risk factors, we want to get to a level where we can do prediction at individual level, at a population level. If I can predict at the time of pregnancy enrollment itself that this woman likely to develop a high-risk factor, you can handhold the woman more. Or if for the population level, we can predict this particular population likely to develop this condition more, like pregnancy-induced hypertension is going to be in, say, Osmanabad, much more. Then government can obviously prioritize resources for it, right? So that is where we want to go, because we work at population level with the states directly. And so this long-term collaboration is ensuring that for every program we have AI incorporated. Yeah, and this particular program I'm personally very, very excited about. It's called Integrated High-Risk Pregnancy Management. And for the gynecologists in the audience, or the faculty in the audience. So we all know this, right? There are 35 high-risk conditions a woman can potentially have during pregnancy. And that leads to mortality of the mother and the neonate. And it's so important if you want to save lives, you have to pick up the risk factor in time and treat in time. Now what I've noticed, we had done a small program in Nandurbar. See, I was telling you, an app is not the solution for everything. We done, Daulatrao has supported this program 2015. Then we developed an app. I thought, oh, we'll develop an app which will help the ANMs algorithm. Like take her through all the symptoms, signs, diagnostics, and then tell her what to do. What happened was, we can only implement the guidelines that already exist. And the guidelines for nurses ended with diagnosis. After that, it's a free-for-all. Then what I realized is this, is that when you look at high-risk factor management, the protocols do exist internationally, but they are only for trained doctors. An obstetrician in urban India, a trained obstetrician can manage a pregnant woman with high-risk factors end-to-end. But in rural India, you have a division of labor, a referral system. The nurse comes in, then the medical officer comes in, then the specialist. Problem with that is that the protocol has now been divided to every level, to their understanding level. There's a need for algorithmic, color-coded, large detailed protocols about how to manage at your level. What should the nurse do? When to refer? What to do? What counseling to give? What medication can she give? What to do when the woman comes back to her? Same thing with the medical officer, who may be an Ayush doctor or an MBBS doctor. What is their part of the role? And then the rural specialist, who may not be as trained as an urban specialist, what is their part of the role? So I was a part of the Antenatal Care Guidelines Committee of Government of India in 2019. They were revising the guidelines after 10 years. There was WHO, UNICEF, John Hopkins, all the big entities. And I raised this point that in addition to operational guidelines, there have to be technical guidelines. And they gave me the go-ahead to do it. So I put together a team of doctors and created, I'm very proud of that effort, and we created in no time last detailed algorithmic color code and nothing left to chance. In fact, when we went down to land detail, we realized that we actually had to have a consensus because, you know, many things are ambiguous, right? Even for doctors, nothing is laid down to the last level, but you couldn't leave it to ambiguity for the nurse. So we really worked hard and built these 3 layers color coded. It was so simplified that if a nurse is never seen a patient of a particular high risk factor, if she has the guideline with her, she'll be able to manage looking at it. And there's a whole vetting that happened. It's just pre-COVID where we had Government of India and Division of Maternal Health and Arman had called dignitaries in the field from all over the country, multilateral agencies, public health officials, state officials, and we went through vetting of 5 protocols, and then COVID started. In the meantime, Telangana government accepted it. So we have a 5-year MOU ongoing with Telangana, which is like hoping for will be a pilot for the rest of the country. What are we doing? We've prioritized 18 high-risk conditions of Telangana, which are responsible for mortality of maternal mothers and neonates in Telangana. We've modified a protocol to suit Telangana with the doctors in Telangana appointed by this government, and now it's become policy there. So we've now once policy, now next is training. So 9,500 nurses, ANMs, 1,500 medical officers, and 350 specialists are getting trained in it. It's face-to-face. We created master trainers of the state who are doing face-to-face training. But training only once doesn't work. You all know that. So next step is guided learning app training. So the good thing in Telangana is all ANM medical officer specialists have a tablet. So all the content has become multimedia. So live action videos, simulations, interactive quizzes, notifications. So the way it is that I train you face to face, then when you go back, there will be one chapter, one anemia. We'll be dedicated 15-20 days on that. We'll send you live action videos, and there will be simulation that you do and come back, and then interactive quizzes, and then notifications. And then we'll keep on testing you, and then 3 months later refresher, like the hand holding. So all the conditions are getting trained, they're getting trained in these conditions in batches. I've trained you, I've created a protocol, trained you, but now I have to hand hold you. So now when they go into the field, the people who train them will be available to answer questions on call center and WhatsApp. So there is a connect. So we've trained, we are handheld, then we have to track. So all the protocols are being layered on the database, RCS database of Government Telangana, where the database ends with diagnosis, but we're going to layer the protocols on top of it. Very simple ones for each high risk condition, so we can track the women. So what will happen is in Telangana is a woman gets pregnant, becomes a part of the database. It's called KCR portal in Telangana, the RCS database. The minute she gets high risk, then the layering of the data of high risk management will track the women. That will lead to dashboard at every level. So imagine the state commissioner of health to the district level will have a dashboard relevant to them. It will tell them how many have which high risk factor. Will be able to pick up where the mistake happened because the protocol will be broken down at that level. And then we know where to go to training, refresher training. So this will be an ongoing iterative process of improvement. Now Telangana, now it's gone to Andhra. We're starting talks with Karnataka, UP we already started talking to, and Rajasthan. So already 5 states is going to go, and then hoping I will go in a manner. Sorry, I think I keep going. Yeah, an iterative model, a pivot model. We are going to refine this process and go through the country, hopefully. And UNICEF is our partner in this program. And I will just say, Kilkari and Mobile Academy are the 2 largest such programs in the world. I must say the numbers. Now, where do you want to go? The future. Imagine you work in digital health, right? So this is and Mr. Koita is in our steering committee, madam. Yeah. So because when we're doing technology, he's so involved in it. So we have a very nice steering committee. Our dream is that eventually when Kilkari and Mobile Academy go through the country, which is already going to happen 2 years time, the data will talk to each other in back end. So Kilkari Mobile Academy and the Integrated High-Risk Pregnancy Management Program talk to each other. So what will happen? And AI integrated. So what will happen if a part of Maharashtra, and Kilkari will come to Maharashtra now next year. So if a part of Maharashtra is doing poor in pregnancy-induced hypertension, then we will use Kilkari to send information directly to the pregnant women on high-risk pregnancy-induced hypertension. Mobile Academy can train the ASHAs more. Integrated High-Risk Pregnancy Management Program can train or handhold the nurses, medical officer specialists more. So we have targeted, nuanced programming that we do. And lastly, I want to talk about this one small program that we're doing in Palghar, right? So I told you we'll train health workers at every level of the cadre, but there are parts of the country like Palghar where nothing works. There's no health system. The roads are, very difficult to, traverse. It's hilly area. There's one bus in the morning, one bus in the evening. So they don't even go for medical care. I mean, you go to Palghar, you work in the Great Sea villages where, I saw a woman, hemoglobin 5 working in the fields, literally that bad. So we are actually upgrading the ASHA workers to the next level, like food doctors. They can go home to home with a kit. They can do blood pressure, hemoglobin, all the diagnostics, and even child monitoring at home. And then they have a tablet, and that's linked to the health system. So we can. So wherever what the need is, we modified our program to suit that particular need. And this is in Palghar. Last slide, few slides. COVID. Because we had built this, and you're going digital health, right? So this is very important. The thing that digital health allows you to do is to build networks. We had this network in place. Government of India, the ASHA network, the nurses network. We had 100 hospitals, 40 NGOs as partners, and then COVID struck. Right? And I'm telling you, there's a lot of skepticism. Many of the NGO partners are not sure, and then COVID really showed that this works. So what happened during COVID lockdown announced overnight? But pregnancy and infancy cannot wait for a lockdown. When there's a high risk factor, if a pregnant woman gets bleeding or child has a problem, you need care immediately. But then they would go to hospitals where it suddenly closed down. There was no antenatal care. It became COVID centers, nowhere to go. So overnight, we started getting calls to the call center. So MMitra the way MMitra works is that we send twice a week in pregnancy, twice a week in infancy information. We have 3 tries for every message in the time slot that they have given. And if they've missed all the 3 tries, they have a missed call system. They can give a missed call system to call them back. And we have a call center where we answer every query. Now the call center was getting questions of medical nature. Right? Overnight, people were calling in emergency, and they were not call center officials, were not doctors. So overnight, we created a virtual clinic, and 60 doctors volunteered, and we handheld over 60,000 women with high-risk factors, emergencies through the virtual clinic. We also gave them support, logistics support, where if anybody needed an ambulance or where to go, which hospital will do ultrasound for you, we matched that, and. Over time, this became a very popular service. It still exists. Next, we added COVID content to the voice calling system. So every 6 weeks we would revise. The second wave was very bad for pregnant women, so we really kept revising. Third thing is, because we had this database of ASHAs, government of India was sending information to ASHAs through our network. So ASHAs would get information on, like for example, how to manage stigma of COVID, how to manage the post, vaccine phase, things like that. So whatever government needed to send, it went through the Mobile Academy platform. And then Har Ghar Dastak, we were part of the campaign, the vaccination campaign. We sent 4.2 million calls to ASHA workers to get the women for vaccination. And now COVID become part of the content throughout our health worker training programs. Our goal eventually is a 5-year scale up where we'll go through the country, 70 million women and their children is our reach. We want to reach, achieve 850,000 health workers is what we want to reach. And the thing is this, look at the number of staff. Only 200. Technology allows you to create scalable solutions. It's very cost effective. We're not building a network of our own, This small staff can manage this huge program just because we do tech plus touch. And this is Arman. And lastly, I just want to talk a little bit of, because there's a gynec department here, and I want to talk about urogynecology, Just lastly, I came back to India with 2 dreams, of course to build Arman through the country, but also develop urogynecology. And also, it was very important for me that whatever I am, and I'm standing here in front of you, is because of training I got in the government health system. It was free. I get, the training I got was momentous, right? And the kind of patients we saw, it is incomparable. And I really saw the beauty of government hospitals, how much work you can do, how much research you can do, how much you can contribute to the field. But the thing that really bothered me was that when I came back from the US, I was trained as a urogynecologist, but the more you are trained, the more you outprice yourself. Poor patients can't get to you. I would be consulting a private hospital and no poor person can come to me. And that really bothered me. My dream was to build the highest end center in a government hospital that will provide the international standards of care to the poorest for free in an environment of dignity and privacy. No overcrowding, one woman. I deal with a field where there's a lot of modesty, that part of the body. They don't want to, imagine swarming women, you talking about your, leaking problems, It is such an inhuman thing. So the dream was to create a center that, really respected their dignity and privacy. And Daulatrao and government, this audience knows this. But urogynecological problems are very women suffer from urogynecological conditions. We all know that. Prolapse, leaking of urine, leaking of feces, constipation, dysfunctional voiding. These are all so common, right? Fistulas. Medical science are artificially divided female pelvic floor into 3, urology, gynecology, and colorectal. But diameter doesn't decide to only affect one part. When a woman has a problem, it will affect all parts equally. But, you go to urologists, they won't understand the gynaec and colorectal part, the gynaec won't understand the other 2 parts. And urogynecology is a beautiful field where you have physiology, functional physiology mixed with, medical, science, medicine, the beauty of medicine, like nuanced treatment and surgical. And the kind of training I got, I really wanted to get to India, and I really wanted to develop the next generation of urogynecology through the country, but in an environment that treated patients well and also fostered research. I'm a researcher in 2D, 3D ultrasound pelvic floor. I teach internationally. I published on it a lot, and I wanted to get that to India, do research integrative health, and I'm master in biological sciences, do basic science a little bit, and foster the research spirit in my, fellows. And for me, medicine, science, service, and research. In that center should become that, beacon for that. It was such a big dream, and Daulatrao and government of Maharashtra supported the dream. In 2018, I signed an MOU with the government of Maharashtra and Daulatrao to build a department of urogynecology, which followed those principles. And the dream was that Kama become tertiary, and then train up professors in 12 medical, all the medical college Maharashtra. Then the secondary level centers start. So that whole of Maharashtra then gets upgraded, in terms of urogyne care. And 2019, I was made an honorary associate professor of urogynecology. Every day 8 to 1, I'm at Kama. And I offer care. And the Department of Urogynecology, service department has now been sanctioned in December 2022. And next step, hopefully, will be a fellowship program, 2-year fellowship program. It's a big dream. As good as the one I went through in Cleveland Clinic. I really hope that happens. And I really hope that we have research. And my students, I have a big dream. I used to go from Cleveland Clinic to IUGA, International Urogyn Association Conference, and we would all present, and my professor would be beaming in the audience. My big dream is we have a whole, students from, Kama, or even if anywhere, if I get associated with PGI, students present international quality work that takes the science forward. We can do that. India has so much numbers, so much data, and so much, knowledge and brilliance here, right? If we can take the field forward, and my students are presenting, and I am, watching them do that, and they take the field forward, it will be a dream come true, that's what I would like to do. And secondly, one very important thing I also want to develop, this fellowship program should have a rural component. What's happened to the field is, and this is happening to a lot of medical science, is that when it's developed in US, UK, Australia, it's a very curative field. It's very machine driven, industry driven, and becomes extremely expensive. Those treatments are so expensive. To get a machine into Kama is like one 50 lakh rupees machine, things like that. The so, I remember I had gone to, in Chhattisgarh, there's a beautiful hospital there, Jan Sastha Sehog. Women come walking 3 days, there. Like they'll come walking 3 days, they stay in the hospital. Yogesh Jain, I know them very well. And they'll stay in the hospital campus, and they'll come and see you once, and they'll never see you again. I have no treatments for them. So you have to develop treatment that speak to the needs of the women who you're treating. Whereas the way medicine has been developed in Europe, is like they want you to come back again and again because then it makes money for the company. So it's so important that you have a rural focus. You involve Indian sciences to develop therapies that work in our context. So I would hope and pray that our fellowship has a 3-month rural components. But 2-3 things will happen. Our fellows will get exposure to what India actually is. They'll come out with a different understanding of what medicine is, and rural urogynecology also will develop. So this is the dream that I've come to, Thank you so much. No, so this is the thing. Now I wanted to create a proper fellowship program. I didn't want it to be a stopgap 2-day, 3-day, which is what we end up doing. And no field should be taught like that. So I want to have a structured program. That is why I'm going to apply to MHS for a structured program. I wanted it to be like stepwise. First, the division develops, the equipment comes in, it's getting renovated, space gets renovated, and then the fellows come to a place where they can really practice. So that's the next step. So as ma'am was saying, competency-based, credit-based modules.
We have to together and work in collaboration with our MU department, which will help you.
I will do that immediately. As soon as I go back, I will start the process. That's the final thing that we are working towards.
Because that is one of the fields after PG's pass in obstetrics. They either go for endoscopy or infertility. But this is one of the fields which is untouched. Not many people are.
See, you're very right.
So, but there is a lot of scope.
There's a lot of scope. And it's a very interesting field. It marries physiology with surgery, with medicine. Secondly, I'll tell you, endoscopy for me is a way of doing surgery. So, and hopefully in each medical college, we can even train professors who are interested in the field. So that they can then take it forward.
In fact, ma'am, it can have its scope model.
Yes.
So you can fit in as a, there, and we can
I will
train
be,
the spokes.
this is a dream. And if that, thank you sir. It will mean a lot because as ma'am had said in the meeting we had, one person cannot do it by themselves. If I train the person here, then they can handle the hub and spoke model and I'll be there, associated with it. I'll be very, very happy to do that.
The second thing I just wanted to ask you, Howard.
No, it's a de-identified data. Is and one, it
Because
follows.
Okay, how
No.
you take any
No,
permission or not?
absolutely. No, so I tell you what happens. I see right now they have data with MMITRA. So MMITRA is where the testing got done. And now MMITRA showed that it works.
Which servers you are keeping it on?
In India.
Cloud-based?
So we work with RailTel. So it's Government of India.
Yeah.
So Kilkari is everything is in-house in India.
Kari will be on NIC.
NIC.
But what about MMITRA?
MMITRA also it is within our own server system. It's not
That's what the whole issue is. Even if it's anonymized,
it doesn't have to be.
your whole research is going to come out on AI algorithms are going to develop on that, where you're capturing and anonymizing and using.
No,
You have to have a very federated architecture, plug and play, which you can have multiple things together.
That is where we are moving towards. In fact, I don't have time, but our tech platform Kilkari Mobile Academy is also improving to be able to allow this, iterative changes.
Yes.
That's what.
And if it's a robust platform, you can have a lot of add-on various modules. Like you've done 3, so you can think of, a problem is identified, you created the architecture. So the same thing can be developed for various modules. Now my question is just one, I think, since one is asking is, how much is the compliance and things? I'll tell you what, this thing, people are getting exhausted with digital inputs coming in. And when you really talk to the ASHA workers, they're not very excited about it.
I
I
understand.
mean, that this is my own interpretation
Absolutely.
of things, and that's one. And the second is, I mean, we're still evolving.
Yes.
So our, connectivity and net availability is not there to the, so we are not able to reach. I mean, it's a lovely this thing which we can scale up, and I think it would benefit with the 5G which comes in, and we try it out with better connectivity, this thing for transfer of data.
Absolutely. The first 2 points. The first point, I completely agree with you that ASHAs get inundated with things to do. The thing is this, what one doesn't realize is that they get inundated with things where they have to input with no return back to them. What we do is to train them to do their work better. So because our thing is focused on...
But this is where the suggestion, this thing is, like we focus on pregnant women, and they are very happy because they're also being incentivized for taking them for, supervised
Yes.
or not a home but a facility-based.
And child health.
And child health. So that's one thing they're pretty, most dedicated is to that compared to the other programs. But at the same time, if it's in such a way that the work is lightened, no one has really looked at that aspect. I mean, if she can in a day have everything sorted out for her. We look from the patient's point, but our backbone, and I'm very worried genuinely that we treat her like a mule of this thing.
Yeah, absolutely.
And she is going to be pressurized with the load. So someone needs to, I mean, since you're doing so much, I would look from the ASHA's workers' point and how can technology be changed to make her life easy?
Absolutely, you've hit the nail on the wall, ma'am. I couldn't incorporate all of this here. 2-3 things that we are doing where we are helping her lighten her load is the fact that, I'll give you an example, right? Number of women in her village with high risk factors. That she does not know. The data will go to her saying that this woman has got this high risk factor. Secondly, because we're taking the counseling onus off from her. See, counseling is work that ASHA has to do, but no ASHA can humanly go and counsel so many women in her village. Kilkari does that. But what we are going to do is that we're linking each Kilkari woman to an ASHA worker. If a Kilkari woman not listening, then ASHA will be told, this woman not listening, just when you go and meet her, tell her. So the counseling is taken off from her, so it lightens her load. Third thing is the content that is being created, hand-holding that's being done is very situational. That will help her in, like the call center, the WhatsApp support. When she has a problem in the field, we'll be supporting her. So the whole idea is to be supportive and rather than prescriptive, so we're keeping it to RCH module 7 and 8, which is the, the specific RCH module. And that we are modifying and very simplified, so simplified. We don't want to make it complex because it has to be nerve level. That's one thing. Secondly, connectivity. I completely agree. I will be the last person to say that tech plus touch is a solution to everything. It's not like I have almost everything looks like a nail. But where things work, if I can use technology to take up the work, then the government can prioritize face-to-face training, etc. In the past, the country where connectivity still is very poor, right? So that is what we want to go towards. Because if you look at lots of south states, all of them have great connectivity. The issue is not there. But if you look at the north, and you look at Bihar, look at Chhattisgarh, etc., there are parts where, of course, there's internet dark. But having said that, all of these also work offline. They're not, and that's where WhatsApp helps, and that's where a thin app if possible. And app also, that's why we are going slow on that, because app doesn't work because they don't have that much data, they won't download it, right? So we're using what they will download and what remains in their phone. So even if when they go to primary, etc., they have connectivity, so it all come to them, and then they can use it when they're offline. So we're looking at all of those, things.
Lots of challenges.
Yeah. Lots of, it's the fun in that, right? Yeah. And things change so soon, ma'am, and we have to be future ready. Because if you're not future ready, things from testing to implementation takes a long time. By the time we implement, they're already there, so. Yeah.
Talk over here. In spite of the personal limitation you're here, we already had a power women of action amongst us. We've seen another one.
Oh my God, don't even begin to compare me.
This is just flowing out.
given a TED talk.
Huh?
She has given a
Achha, is it okay?
Yeah. I'm a TED Fellow 2020. Yeah.
Because that is what we just witnessed here, and
Thank
this
you.
is just a spontaneous reaction that wow, every word that you said was a word of action. Just as ma'am says, no theory, the student's perspective, I felt you have touched so many minds that this is going to go like a spear ball. And from my
Thank you.
side,
I hope this is recorded and going to be put on our website. Yeah.
No, thank you. This means a lot, that you said that, really a lot, I mean, nowhere do you get this free training of a high caliber, right? Quite a high caliber. I mean, there's a lot of improvements that we made. That is always the case. But it's inspirational. And I really hope that, this network of government hospitals, where does it exist? You go to US, it's not private systems. They have no public health. We have public health. Right? Vaccinations will scale up through the country. There's so many positives. And we do it for such a huge number, right? I mean, in Mumbai is Nepal size. Right? I mean, so, we always deride India, but there's so much possible, right? And honestly, one more thing I'll say, women like me, and I'm nowhere near man, but we can exist in India. And the kind of countries we're surrounded by, right? Where can you have women leaders other than in India, right? And Maharashtra especially, I'm a Kannadika, but Maharashtra is very egalitarian. It allows, there's a lot of support for women who are, who can do things. So hold on to that. I mean, the only thing, like, I must say this, right? A lot of us came out of residency feeling like victims ourselves. But there's another way to look at it. Look at the opportunity. Look at what is possible. Look at how this system benefited me. Can I take it and help others with it? Because all of us were we as an accident of birth. We opened our eyes and we were our parents' children and we went to school and that's why we are here. I'm acutely aware of that, right? That it's just an accident of birth. It's just a random thing, So if we can help our brethren get what we got, And last thing I must say, and this is one point I want to just say in just 2 minutes, is that as doctors know, we look at it very clinically. Okay, I give information, there will be knowledge record, behavior change, health outcome, we use those terms. The thing that really struck me was empowerment. Honestly, information is empowerment. These women are not, I hate the word charity, right? It's not charity. These are women who are smart, intelligent, for various circumstances, often beyond their control, actually always beyond their control, they are where they are. You ignite that spark, you see how they blossom. What we found was women were empowerment intergenerational. Right? I'll give an example, right? There was this, a woman from UP, right? Like in movie you have Gungat and in Andheri slums. And Arman would, the information is going in, it talks about things like sex during pregnancy, when the child will understand psychosocial stimulation, how do you do psychosocial stimulation to the child, when the child understands color, it goes to that detail. So it's a lot of, emotional support and things that you and I care about. And this woman was so inspired, she put a girl child in English medium school and stopped wearing the gungat. And because she knew things that are right, and she would stand up to her in-laws, she would stand up, to her husband. Another Muslim woman, and I remember this, from Andheri slums only, she was the wife of an Azan teacher. First pregnancy, emitter was not there. She got pregnant again within 3 months, because no contraception, breastfeeding time, she got pregnant. She knew that there should be spacing. Internally you understand this, but no one supported her, they didn't allow her to abort, right? So she had to go through the second pregnancy, and then she got emitter in second pregnancy. And what emitter told her, spacing. You have to have 3 years between each child, why your body's health is so important, anemia and all of those things. So she was convinced. She stood up to her husband and said, after this child, they're going to, do family planning. And he agreed. Right? And she told us this. Right? And I remember once we had gone with donors to Mankur slums. And there was a Burkha-clad women, sitting in the, and these are women who haven't spoken to anybody other than a husband and a mother-in-law on the phone. Right? And then suddenly, because they're getting this information, they feel they matter. So think this, right? What would happen is that somebody's coming to you, voice calls every week. I have a query, I can call the call center, there's a missed call system, so we supported. They blossom. So somebody, the donors asked, the international donors, a white man asked, what do you like about the service? Then one Burkha-clad lady, she was Burkha-clad, you didn't even see her face. She said, talks about things that taboo in our community. It talks about sex during pregnancy. She said this. I was shocked. It's like it's just the ability to speak up and speak about what is important for them, and what hurts them. So the empowerment angle, Yeah. Sorry, I just took off from your thing and I don't touch it. Sorry.
Just one more question from my side. I'm from the Ayush background.
Yes.
So you mentioned the integrated protocol.
Yes.
I don't know the plan right now, but just a thought that whatever plans and management सेल ये करते हैं, IEC करते हैं, information देते हैं. Can we add a integrated component, very simple, which already PHI schemes through RBS and Janani Matu Suraksha Yojana are doing? For example, Ayush intervention, just simple Munakka Kara. So, these are little things which, as ma'am said, compliance बढ़ती है. So, I don't know.
We'll be very happy if
we
it's.
have a module, like, अनुलोम विलोम करने से उनका जो hypertensive है, preeclampsia में land होते हैं. So, there are certain things which have proven evidence-based as Ayush intervention. And the government of India, through Ministry of Ayush, have been doing these trials for 3 years now. Since you have the database of
Absolutely, evidence-based stuff. A couple of things where it can be integrated, right? One is, as ma'am and I both are interested in dysfunctional voiding. People who can't pee, and they don't pee. Women can't pee, or adolescent girls can't pee because they tend to squeeze up their pelvic floor subconsciously. So a lot of meditation, relaxation techniques are important, right? So that is one thing. Second thing, from the Ayush perspective, the Ayurveda perspective, there are a lot of anti-inflammatory mediated products, and we deal with bladder pain syndrome, which is an inflammatory condition. And there are all the so the medication we use on Western basis, So there's a whole chance of research to understand is there any anti-inflammatory Ayurveda product which can work in bladder pain syndrome patients. So many women work on bladder pain syndrome. So so research can be done in multiple ways. The content can be added to Kilkari 100%. In fact, I'll connect with you and we can, find out that. And even the urogynecology work we do in Kama, there can be a component to it, It's almost time, right?
Ma'am has to go for another meeting. We'll carry on with the tea time.
Yeah.
Let's finish with the, let's take this last question.
I think we need to get her back. Let's finish this last one.
We have got a good registry of BPC cases,
Okay.
peripartum cardiomyopathy, and we published in 2018 in AFMC in 43 cases, which are the history
Okay.
published at that time. We are still working on that. We using your platform, particularly the patient registered and mortality occurred, or the patient registered with the breathlessness. Can we add on our work and collaborate?
Absolutely. I'll connect with you offline.
Yes, ma'am.
Because we are working on this high-risk model. Heart disease is a big part of it. If you look at the high-risk conditions, heart disease is a part of it. In Telangana is there. So we can very have, this is
we
what...
have got all the, around the Nashik, we have got our eco machine, we monitor it well, and we have delivered many of the cases very successfully in our hospital. And second thing is the GDM.
GDM.
Very
It's a
close
very,
to our heart.
GDM is very...
And we want to work with you, and we have got a fetal-maternal specialist also. He is working with us. Thursday we have got the clinic also, when they come with that. And
Yeah, GDM is also a very important part. GDM is another 5, like big major high-risk factors in pregnancy, of course.
I am Dr. Maternal. I am a physician in medicine. I am product of Fernandez Hospital, Tibetan.
Okay.
I basically work in obstetric medicine.
Obstetric medicine.
And will get connected.
Very happy, very happy. I know Anita Fernandez ma'am very well.
we have got
Yeah.
some 70, 80 cases already registered from.
चाय भी चर्चा चलेगी. That was what I wanted to know. Felicitation.
Pregnancy and motherhood are not diseases. No mother, neonate, infant or child dies for want of care. The desire captured in the name Arman, which stands for wish in Hindi and Ichha in Marathi, Hindi and Sanskrit, Devanagari. Touch of affection plus leveraging technology to get scalable solutions, empowering mothers and enabling healthy children. Thank you very much, Dr. Aparna Hegde ma'am, sharing your experiences with all of us. May I request your Honorable Vice Chancellor Madam to come up on the stage. I also requested the Vice Chancellor and Registrar.
Fantastic. Thank you. And now you're officially with us as part of
Sir.
It's a milestone in my
Yeah.
life,
Yes.
for my company.
Well, I agree with me. In a number of my talks, I've asked, say that, finally each one has to find your own ikigai. I think she's found hers.
Great.
And more than that, since she's found her way, I'm sure she's given you all, especially lots of faculty and students here, a map, which I said she's ready to take on the mentorship role. Just follow her attitude and passion, and everyone will reach destination. Great. You are welcome.